Welcome to the Science of Ageless Living. I'm Dr. Ethan Hausman-Marquis. I'm a doctor scientist and the only peptide clinic physician in London with a published body of work specifically in this field. Every episode takes one subject and works through it properly: the real biochemistry, the honest evidence base, what we know, what we don't, and what the regulatory picture actually looks like. No hype, no discount codes, just the science. Today, the GLP-1 receptor agonists. And one specific question about them, not do they work. We know they work. That question is settled to a degree that almost nothing else in this field is settled. The question I want to ask is the one that comes after. What happens when you stop? Because here's the situation we are actually in. These are the most effective pharmacological agents for weight loss ever brought to market. They are being prescribed at a scale that has no precedent in metabolic medicine. And the majority of people who start them will stop them within a year, most of them. Real-world persistence data is considerably worse than trial data, and trial data is already not what most people imagine. So we have an intervention with extraordinary efficacy deployed at population scale where the modal patient experience is discontinuation, and the science of what happens at that point, the off-ramp, is dramatically less developed than the science of what happens when you start. That gap is the subject of today's episode. What the discontinuation data actually shows, why the body does what it does when the drug is withdrawn, whether anything is retained, what the emerging strategies are for coming off, and whether any of them are supported by evidence, and what the honest picture looks like for anyone in this field. Let's establish the pharmacology properly, because the off-ramp question only makes sense if you understand what's being switched off. GLP-1, glucagon-like peptide 1, is an incretin hormone. It's a 30 or 31 amino acid peptide cleaved from proglucagon, and it's secreted by the L cells of the distal small intestine and colon in response to nutrient arrival in the gut. Its native half-life is remarkably short, somewhere between 1 and 2 minutes. It's degraded almost immediately by dipeptidyl peptidase 4, DPP4, which cleaves the two N-terminal amino acids and inactivates it. That short half-life is the central pharmacological problem the entire drug class was built to solve. Native GLP-1 is a beautiful signal and a useless drug. You cannot dose something with a 2-minute half-life. The solutions were elegant. Exenatide, the first agent in the class, was derived from exendin-4, a peptide isolated from the venom of the Gila monster, which happens to be a GLP-1 receptor agonist resistant to DPP4 cleavage. Later agents took the human peptide and engineered around the degradation. Semaglutide substitutes the alanine at position 8 with alpha-aminoisobutyric acid, which blocks DPP4 cleavage, and attaches a C18 fatty diacid chain via a linker, which drives high-affinity binding to serum albumin. That albumin binding is the key to the pharmacokinetics. It creates a circulating depot, protects the peptide from renal clearance, and extends the half-life from 2 minutes to approximately 1 week, which is what makes weekly dosing possible. Tirzepatide does something structurally different and worth understanding. It's a single peptide that agonizes two receptors, the GLP-1 receptor and the GIP receptor. GIP, glucose-dependent insulinotropic polypeptide, is the other major incretin, secreted from K cells in the proximal small intestine. The dual agonism appears to produce greater weight loss than GLP-1 agonism alone, and the mechanistic explanation for why is still genuinely contested, which is a good sign that there's real biology there, rather than just a marketing differentiation. Now, where do these drugs act? The pancreatic effect is the one everyone learns first. GLP-1 receptor activation on beta cells potentiates glucose-dependent insulin secretion. The phrase glucose-dependent carries a lot of weight there. The effect scales with ambient glucose, which is why these agents don't cause hypoglycemia the way sulfonylureas do. They also suppress glucagon secretion from alpha cells, again, glucose-dependently. But the pancreatic effect is not why people lose weight. The weight loss is central, and it is primarily hypothalamic. GLP-1 receptors are expressed in the arcuate nucleus of the hypothalamus, and activation there produces two coordinated effects: stimulation of POMC and CART, expressing neurons, which are anorexigenic. They suppress appetite and inhibition of the NPY/AGRP neurons, which are orexigenic. So you're pushing both arms of the melanocortin system in the same direction. There's additional signaling in the area, post-rema and nucleus, tractus solitarius, in the brainstem, which mediates satiety and, less helpfully, nausea. And there's a peripheral contribution from delayed gastric emptying, which is significant early in treatment and appears to attenuate somewhat with continued exposure. There is also, and this is where the story gets more interesting than appetite suppressant or activity, in mesolimbic reward circuitry. GLP-1 receptors are present in the ventral tegmental area and nucleus accumbens, and agonism appears to reduce the incentive salience of food. This is the mechanism most likely underlying the anecdotal reports of reduced alcohol consumption, reduced nicotine craving, and in some reports, reduced compulsive behaviors unrelated to food. That signal is real enough that formal trials in alcohol use disorder are running. So, when a patient is on one of these drugs, they are not simply eating less through willpower. They are living inside a pharmacologically altered appetite regulation system. The hunger signal is genuinely attenuated at the hypothalamic level. Food occupies less cognitive space. Patients describe the disappearance of what has come to be called food noise, and that description is mechanistically coherent. You are damping the tonic drive from AGRP neurons that generates it. Hold that picture, because the off-ramp question is precisely this. What happens to a system that has been running on that altered signal for a year when the signal is withdrawn? Let me take you through the trials, because the numbers here are specific and they matter. The foundational data set is the Step 1 trial extension. Step 1 was the pivotal semaglutide 2.4 milligram weight management trial, 68 weeks, and a mean weight loss of roughly 15% of body weight, which at the time was without precedent for a pharmacological agent. What made the extension study valuable is that a subset of participants stopped both the drug and the lifestyle intervention at week 68 and were followed for a further year. The result, published in Diabetes, Obesity and Metabolism in 2022, participants regained approximately 2/3 of the weight they had lost. And critically, this is the part that gets less attention than it deserves. The cardiometabolic improvements reverted in parallel: blood pressure, lipid profile, HbA1c, C-reactive protein. These had all improved substantially on treatment. They moved back toward baseline as the weight returned. Step 4 approached the same question with a cleaner design. Everyone ran in on semaglutide for 20 weeks to reach the maintenance dose. Then participants were randomized either to continue or to switch to placebo, with lifestyle support maintained in both arms. Published in JAMA in 2021. The continuation group went on to lose approximately another 8% of body weight over the following 48 weeks. The withdrawal group regained approximately 7%. So the divergence between continuing and stopping was on the order of 15 percentage points of body weight over less than a year. That's the size of the entire treatment effect of most older weight loss drugs, appearing purely as a function of whether you kept taking it. SURMOUNT-4 did the equivalent for tirzepatide, published in JAMA in 2024. 36-week open-label lead-in, then randomized withdrawal. Over the following year, the placebo group regained around 14% of body weight. The continuation group lost a further 5.5%. 3 trials, 2 molecules, consistent direction. The effect is durable while the drug is present and substantially reverses when it isn't. Now, I want to characterize this carefully because there are 2 ways to read it, and only one of them is scientifically honest. The uncharitable reading is that these drugs don't really work, that the weight comes back. So what was the point? That reading is wrong, and it misunderstands what kind of intervention this is. The correct reading is that obesity is behaving here exactly like every other chronic condition we treat pharmacologically. Blood pressure rises when you stop an antihypertensive. LDL rises when you stop a statin. Nobody frames that as the statin having failed. We understand hypertension and dyslipidemia as chronic conditions requiring chronic management, and we don't expect a durable cure from a drug that treats them. The reason GLP-1 discontinuation feels different. The reason it generates disappointment and headlines is that we have culturally coded obesity as a behavioral failure amenable to a corrective intervention rather than as a chronic, biologically defended state. The discontinuation data is, if anything, the most powerful evidence we have that the biological framing is the correct one. The body defends its adipose mass with the same tenacity with which it defends anything else physiologically important. The drug doesn't change that. It overrides it temporarily for as long as it's present. That's not a failure of the drug. It's a fact about the system it's acting on. But it does mean that anyone starting one of these agents with the mental model of a course of treatment, a finite intervention, producing a permanent result, has been misled and will be surprised in a way that predicts discontinuation and regain. Let's go into the physiology, because the weight comes back is a description, not an explanation. The relevant framework is what's sometimes called metabolic adaptation, and the underlying work substantially predates GLP-1 agonists. Rudolf Leibel and Michael Rosenbaum's studies at Columbia, running from the mid-1990s onward, established that weight loss in humans provokes a coordinated defensive response that is disproportionate to the weight lost. Two components. First, energy expenditure falls by more than body composition change alone predicts adaptive thermogenesis. A person who has lost 10% of their body weight burns meaningfully fewer calories per day than a person of the same weight and composition who never lost it. Estimates in the older literature run to a few hundred kilocalories a day of unexplained deficit. Second, and more powerfully, the appetite signaling changes. The hormonal picture here is well characterized, and the key human data set is Sumitran and colleagues' 2011 paper in the New England Journal of Medicine. After diet-induced weight loss, circulating leptin falls disproportionately, more than the fat mass reduction alone accounts for, and leptin is the primary long-term adiposity signal to the hypothalamus. Low leptin releases the brake on AGRP neurons. Simultaneously, ghrelin rises above pre-weight loss levels. Peptide YY and cholecystokinin, satiety signals, fall. And the crucial finding in that paper was longitudinal. These changes were still present at 12 months. This is not a transient adjustment. The altered appetite signaling persists. So consider what the hypothalamus of a patient on semaglutide is experiencing after a year of treatment. They have lost 15% of their body weight. Every one of those counter-regulatory mechanisms has been engaged. Leptin has fallen, ghrelin has risen, satiety, peptides have declined, energy expenditure has adapted downward. The full defensive apparatus is armed and pointed at weight regain, and it has been completely masked by pharmacological agonism at the same receptors the system uses to signal satiety. Now withdraw the drug. The albumin-bound depot clears over a few weeks. With semaglutide's week-long half-life, you're looking at something like 5 weeks to functional washout. And what emerges is not the appetite of the patient before treatment. It's the appetite of a person who has just lost 15% of their body weight with all the counter-regulation that entails and no longer has anything opposing it. This is why the regain is not a matter of insufficient discipline. The patient is not returning to their old eating pattern. They are encountering, often for the first time, the full unopposed force of a weight-reduced hypothalamus. They typically describe it as the food noise coming back and coming back louder than it was before they started. I think that's the single most important thing to communicate to a patient contemplating either starting or stopping these drugs. The drug did not repair the regulatory system. It substituted for a piece of it, and the underlying system during the entire treatment period has been quietly moving in the opposite direction. There's a second issue with discontinuation that receives considerably less attention than the weight regain. And from a longevity perspective, I'd argue it matters more. When people lose weight, by any method, they lose both fat and lean tissue. That's not specific to GLP-1 agonists. The typically cited figure across the weight loss literature is that somewhere between a quarter and a third of the mass lost is lean tissue, and body composition sub-studies of the GLP-1 trials have reported proportions in that general range, with some analyses at the higher end. Two reasons this matters more here than in the older literature. The first is magnitude. When a diet intervention produces 5% weight loss, the lean tissue component is small in absolute terms. When a drug reliably produces 15 to 20% weight loss, the same proportion represents a substantial quantity of skeletal muscle. The second is the asymmetry of regain, and this is the crux. When weight returns after discontinuation, the evidence from the broader weight cycling literature indicates that fat mass is restored preferentially and more rapidly than lean mass. So a completed cycle, down 15%, back up 15%, does not return the patient to their starting composition. It returns them to their starting weight with a worse ratio, less muscle, more fat, at the same number on the scale. Repeat that cycle several times across a decade, as many patients will if they start and stop repeatedly, and you are looking at a trajectory that runs directly counter to everything we understand about healthy aging. Skeletal muscle is not merely locomotor tissue, it's the principal site of insulin-mediated glucose disposal, a substantial endocrine organ in its own right, and the strongest modifiable determinant of functional independence in later life. Muscle mass and strength in midlife are among the better predictors of late life outcomes we have. There is a genuine possibility, and I want to be careful because this is inference rather than demonstrated outcome, that repeated GLP-1 cycling could produce sarcopenic obesity in a population that would not otherwise have developed it, and do so at a younger age. That is a hypothesis, not a finding. The drugs have not been deployed at scale for long enough to have the longitudinal data, but it is a hypothesis that follows fairly directly from established physiology, and I don't think it's receiving proportionate attention relative to the enthusiasm. This is also why the muscle preservation pipeline has attracted the investment it has. Myostatin and activin pathway inhibitors, bimagrumab, is the most advanced, with others including apitegromab and trevogrumab in development, are being trialed specifically in combination with GLP-1 agonists, with the explicit goal of shifting the composition of the weight lost toward fat. Whether they deliver that in humans at acceptable safety remains to be established, but the strategic logic is sound, and it's a recognition from within the industry that composition, not just mass, is the real endpoint. In the meantime, the evidence-based mitigation is unglamorous and well-established. Adequate protein intake during the weight loss phase and progressive resistance training throughout. Both are supported independently of the GLP-1 context, and neither is optional if the objective is health span rather than a number. So, is the off-ramp entirely a matter of loss? Does anything survive discontinuation? Here the honest answer is probably some things, and we know less than we should. The most important consideration is cardiovascular. The SELECT trial, published in 2023, showed that semaglutide reduced major adverse cardiovascular events by approximately 20% in people with overweight or obesity and established cardiovascular disease without diabetes. That is a hard outcome result, and it changed how the class is understood. These stopped being weight loss drugs and became cardiometabolic drugs that also produce weight loss. The relevant question for us is whether that benefit persists after discontinuation, and the honest answer is that the trial wasn't designed to tell us. What we can reason from is the mechanism. A meaningful portion of the cardiovascular benefit appears to be independent of weight loss. There are direct anti-inflammatory and probable direct vascular effects, which suggests it is likely to be contingent on continued exposure. Additionally, insofar as the benefit is weight-mediated and the weight returns, the benefit would be expected to return with it. That is exactly what the Step 1 extension showed for the intermediate markers. Blood pressure, lipids, inflammatory markers, all reverted alongside the weight. There is a concept in cardiovascular medicine, sometimes called legacy effect or metabolic memory. The observation, most clearly demonstrated in the diabetes literature, that a period of good glycemic control confers durable benefit even after control deteriorates. It's usually attributed to reduced accumulation of advanced glycation end products and to persistent epigenetic modification in vascular tissue. Whether a period of GLP-1 exposure produces an analogous legacy is an open and genuinely interesting question. It's plausible. It is not demonstrated. What is more clearly retained in some patients is behavioral. A meaningful proportion of patients use the treatment period to establish eating patterns, food preferences, and activity habits that are easier to build when appetite is pharmacologically quieted, and some of that carries. It's not nothing, but the trial data tells us plainly that it's insufficient on its own to prevent regain in the majority. The step 4 and surmount 4. Withdrawal arms had continued lifestyle support and regained anyway. And there's a subtler point worth making. There's a reasonable argument that the transient benefit is still a real benefit, that a year at 15% lower body weight with improved blood pressure and glycaemia and reduced inflammatory burden is a year of reduced cumulative exposure to metabolic risk, and that cumulative exposure is what drives atherosclerotic and metabolic disease over decades. On that framing, even a fully reversible intervention buys something durable, because the damage it prevented during the exposure window doesn't retroactively occur. I find that argument persuasive in principle. I'd want to see it demonstrated rather than asserted. This brings us to what is currently the most active area of practice in this space, and I should be clear, one where practice is running well ahead of published evidence. Let me go through the main approaches and label the evidence honestly in each case. The first is simply not stopping. Chronic therapy, indefinitely, as with an antihypertensive. This is the approach with the strongest evidence base, for the straightforward reason that it's what the trials studied. If the objective is durable weight and cardiometabolic benefit, continuing the drug achieves it. The obstacles are cost, long-term safety data that extends to years rather than decades, tolerability, and the fact that most patients do not want to be on an injectable indefinitely. Real-world persistence figures reflect that plainly. The second is dose reduction to a maintenance level, often called maintenance dosing, sometimes microdosing, though I dislike that term because it borrows credibility from a different field. The logic is that the dose required to induce weight loss may exceed the dose required to maintain it, so the patient steps down to a lower dose that holds the weight with fewer side effects and lower cost. The mechanistic rationale is reasonable. Receptor occupancy sufficient to hold appetite at a new set point may plausibly be lower than that required to drive continued loss. What we lack is trial evidence. There is no adequately powered randomized study establishing what the maintenance effective dose is, whether it differs by individual or whether it holds over years. This is being done widely in clinical practice on mechanistic reasoning and clinical observation. That's a defensible basis for practice and an inadequate basis for confident claims, and those should not be confused. Third, tapering rather than abrupt cessation, reducing the dose stepwise over months rather than stopping outright, with the intention of allowing gradual reemergence of endogenous appetite, signaling rather than an abrupt unmasking. Again, physiologically sensible, essentially unstudied. I'd note the pharmacokinetics do some of this automatically. With a week-long half-life, even abrupt discontinuation produces a washout over several weeks rather than overnight. Whether a deliberate taper improves on that meaningfully is unknown. Fourth, bridging to a mechanistically distinct intervention. This is where the fractal health data belongs. Their Revita procedure is a duodenal mucosal resurfacing, an endoscopic hydrothermal ablation of the duodenal lining, originally developed for type 2 diabetes, with the underlying premise that the duodenal mucosa becomes maladaptively altered in metabolic disease, and that resurfacing, it restores more normal enteroendocrine signaling. Their Reveal-1 study reported that patients who underwent the procedure after GLP-1 discontinuation retained approximately 78% of their GLP-1 associated weight loss. That number deserves interest and equally deserves caution. Early phase, small, and the appropriate comparator matters enormously. The meaningful comparison is against a randomized control group discontinuing without the procedure, not against historical regain data. But it's the first serious attempt at an actual off-ramp technology rather than an off-ramp protocol. And conceptually, it's the right idea. If the problem is that the drug substitutes for a signaling function, then a durable solution has to restore the signaling rather than simply withdraw the substitute. And fifth, the frontier, the oral and next-generation agents. Orforglipron, a small molecule oral GLP-1 agonist, changes the practical calculus of chronic therapy substantially. Much of the resistance to indefinite treatment is about injections and cost, both of which an oral small molecule addresses. Retatrutide, a triple agonist adding glucagon receptor activity to the GLP-1/GIP combination, has produced weight loss figures in early trials that exceed anything previously seen pharmacologically, which will make the composition and discontinuation questions correspondingly more acute rather than less. The direction of travel is fairly clear. As these agents become easier and cheaper to take, the discontinuation question may partly dissolve because the answer for most patients becomes don't. But that's a resolution by circumvention. The underlying biological question, can you produce a durable reset of a defended set point, remains, and it's the more scientifically interesting one. So where does this leave us in 2026? What we know with confidence, these are the most effective weight loss agents ever developed, and their efficacy is contingent on continued administration. 3 randomized withdrawal studies across 2 molecules show consistent, substantial regain, with cardiometabolic markers reverting alongside. The physiology explaining this is well established and predates the drug class. Weight loss provokes a coordinated defense involving leptin decline, ghrelin elevation, reduced satiety signaling, and adaptive thermogenesis, and that defense persists for at least a year and is masked, not resolved, during treatment. What we know with moderate confidence, body composition changes during weight loss and regain are asymmetric, with lean mass lost readily and regained poorly, and the magnitude of loss achievable with these agents makes that a more serious concern than it has been historically. What we don't know, and should be honest about, whether cardiovascular benefit shows any legacy effect after discontinuation, what the effective maintenance dose is, or whether it can be defined generally, whether tapering improves on abrupt cessation, whether any bridging technology produces genuinely durable results in adequately controlled studies, what repeated cycling does to body composition and metabolic health over decades, and whether any intervention can produce a durable downward reset of the defended set point rather than a temporary override of it. That last question is, I think, the most important open question in metabolic medicine right now. Everything else is engineering around it. My practical position, and I'll state it plainly, if a patient starts one of these agents, they should start with an accurate model of what it is, a chronic therapy for a chronic condition, not a course of treatment. If the intention is to stop at some point, the planning for that should begin at initiation, not at discontinuation, protein intake, and resistance training established from week 1, not introduced when the drug is withdrawn. And anyone presenting these drugs as a finite intervention with a permanent result is either not reading the withdrawal trials or is choosing not to mention them. The drugs are remarkable. What they are not is a cure, and the gap between those two statements is where most of the patient disappointment in this field is generated. That's GLP-1 off-ramps, a class of molecules that overrides one of the most robustly defended systems in human physiology, works extraordinarily well for as long as it's present, and hands the patient back an unopposed and fully armed counter-regulatory apparatus the moment it isn't. The science of getting on these drugs is mature. The science of getting off them is, frankly, about a decade behind, and given how many people are going to need it, that's a gap the field should be considerably more embarrassed about than it currently is. In the next episode, we'll take the natural sequel to this one, the muscle question. what actually happens to skeletal muscle during rapid pharmacological weight loss, whether the myostatin and activin inhibitors now in trials can change the composition of what's lost, and what the honest evidence base looks like for preserving lean mass through a weight loss phase. We'll do it the same way: what it is, what the proposed mechanisms are, what the evidence actually shows, and what the honest picture looks like. If this is useful to you, share it with someone who's navigating this space. This field deserves more rigorous public discussion and less noise. I'm Dr. Ethan Hausman Marquis. This is the science of ageless living.